Okay, welcome everybody to the latest installment of the World Trade Center Health Program's Clinical Best Practices. Today's webinar is titled Substance Use in Trauma-Exposed Populations, Essentials for Screening and Intervention. And with us delivering the webinar are two well-known and highly esteemed speakers. First, Dr. Sandra Lowe, who's the Medical Director of the World Trade Center Mental Health Program at Mount Sinai Clinical Center of Excellence. And she is also an Associate Professor of Psychiatry and Environmental Medicine and Public Health at the Icahn School of Medicine at Mount Sinai. Also joining us is Dr. Frank Dowling, who is the Medical Director of the Long Island Behavioral Medicine and is also a Clinical Associate Professor of Psychiatry at Stony Brook School of Medicine. Disclaimers are that the views expressed in this presentation are those of the speakers and don't necessarily represent the views of NIOSH and CDC. Any mention of trade names, commercial practices, or organizations does not necessarily imply NIOSH CDC endorsement. And finally, citations to websites external to CDC NIOSH do not constitute their endorsement of the organization or their programs or products. Furthermore, CDC NIOSH is not responsible for the content of those websites. And then finally, we do have one disclosure from one of our planning committee members, Dr. De La Hoz, participated in some promotional programs hosted by pharmaceutical companies, but those relationships have been mitigated. And with that, I will now pass the podium to Dr. Lowe. Take it away, Dr. Lowe.
Thank you very much, Dr. Calvert. So today we are going to speak about substance use in World Trade Center responders and survivors, populations whose substance use is associated with physical and psychological trauma exposure. And this is an important consideration because substance use in the context of trauma presents some unique clinical challenges and also affects strategies for screening and for treatment. We have no conflicts of interest, and there will be a discussion of off-label uses of medications for addiction treatment. So a brief outline, I'll start with a brief review of 9/11 exposure and mental health consequences, and touch upon the association of trauma exposure with substance use disorders, as well as some of the clinical challenges of comorbidity. Dr. Dowling, an expert in addiction medicine, will discuss the health impact of alcohol use and best practices for management of alcohol and opioid use disorders with a focus on medication for addiction treatment. I will then finish up with a discussion of some of the psychosocial strategies. The World Trade Center terrorist attacks have been extensively discussed. However, the magnitude and the enduring health effects of this disaster remain striking. Individuals were over 3,000 individuals were killed. There was exposure to severe environmental stressors. People suffered severe injuries as they tried to escape the burning towers, as well as the terrible dust cloud. They witnessed horrific events and lost many colleagues and friends and sometimes family members. It's important to remember that the duration of the exposure was not just for that day or the days afterward. The whole work that took place at the World Trade Center site lasted almost a year. And during that time, the workers and other individuals lacked sufficient PPE, and many of them had no disaster response training. So despite the intense exposure that some individuals experience, most did not develop any lasting psychological symptoms. And that's because emotional resilience is the most common response to trauma exposure. That is, trauma exposure on its own does not result in adverse psychological effects. There are a multitude of interlocking factors that are going to determine the prevalence and the course of psychological illness. Okay. Nevertheless, we do know that for many individuals, 9/11 exposure resulted in significant health consequences, especially in vulnerable individuals. And currently, many thousands of World Trade Center exposed people are experiencing the cumulative effects of 2 decades worth of uh, psychological and physical illnesses. Within the enrolled members of the World Trade Center Health Program, 64% have at least one certified condition, and 22% are certified with both physical and psychiatric World Trade Center related conditions. That is, it does not include non-World Trade Center exposure-related conditions such as hypertension or diabetes or attention deficit disorder. And the World Trade Center Health Program was established to identify and address these health needs. And as you know, it provides no-cost screening and surveillance, treatment for all certified conditions, including, of course, substance use disorders. And it also provides, very importantly, case management services, which is critical for care coordination, especially when there are multiple diagnoses. So these are the psychiatric conditions that are accepted by the program as related to exposure. PTSD is the most often certified diagnosed condition, psychological condition within our program. And I've listed here some of the diagnostic criteria. Some of you are very familiar with them. Basically, there has to be exposure to a severe trauma. Individuals develop intrusive thoughts and images such as nightmares and flashbacks. There is a persistent avoidance of anything associated with trauma reminders. Negative moods, very thoughts that are hopeless or lack of trust in others, and hyperarousal symptoms, heightened reactivity. This would be symptoms like irritability or being on edge, very distressing symptoms. Okay, so I am going to focus on PTSD and substance use disorder, conditions that are highly comorbid. According to the National Epidemiologic Survey from 2015, more than 50% of patients with PTSD meet lifetime criteria for substance use disorder. However, if you take a look at the chart demonstrating the certification data by number of members, you'll see PTSD at 16,000. This is from about end of September. And substance use, a mere 1,600. Now, the reason that the prevalence is not reflected in the certification data is that it has to do with certification practices. And by that, I mean that clinicians who are certifying someone may only certify, say, for depression or PTSD and not include a concurrent substance use disorder. Some of this is just for practical reasons. If someone is certified for PTSD, they are eligible for treatment of substance use disorder. It falls within that umbrella. Also, stigma contributes, and individuals may underreport, or the substance use may not just be evident at the time of the presentation. So all of this contributes to suboptimal healthcare if you don't know exactly what you're treating. Now, although research on 9/11 and substance use disorders is limited, there are several studies that have taken a look at exposure and found that there are associations between 9/11, PTSD, and substance use. Early studies found that there was an increase in substance use among Manhattan residents, which is not at all uncommon following a disaster or a terrorist attack. However, this pattern of increased use persisted, with 25% of responders reporting high-intensity binge drinking more than 10 years post 9/11. Another significant finding was that a frequent binge drinking to intentionally self-medicate PTSD symptoms, and that has been reported more than 15 years after 9/11. Several other studies have documented elevation in hospitalizations and drug-related mortality in responders with dual diagnoses. So there are various theories that have been proposed to explain this association between trauma and substance use. The self-medication model is the best known and most supported of these theories. And essentially, it states that individuals with PTSD have a higher incidence of substance use because they use the substances to mitigate their trauma symptoms. Another theory is the shared vulnerability theory, which states that both conditions develop concurrently, and that's attributable to shared risk factors, whether they're genetic or biopsychosocial. And then there's a high risk theory, which states that substance use disorder, particularly being intoxicated, is going to increase the likelihood of individuals placing themselves in situations where they're more likely to experience trauma. This is from a study by Gary and colleagues in 2020. And it looked at almost 30,000 individuals from the World Trade Center Health Registry and found that 15 years after 9/11, there was intentional self-medication of PTSD symptoms, and that there was a dose-response relationship here. The odds of binge drinking increased with the number of PTSD symptoms. And there you see the on the bottom, the symptoms clusters endorsed, the prevalence of high frequency binge drinking, and clearly you see the increase of use specifically to self-medicate. Okay, in addition, there is the dual maintenance model. And essentially this is states that PTSD and substance use disorders have overlapping effects on the stress response system. That is, both result in a systemic dysregulation of the neuroendocrine, immune and inflammatory systems, and they both have similar effects in areas of the brain that are involved in both conditions, like the amygdala, the hippocampus, and various cortical areas. This, of course, impacts brain development, cognition, emotional regulation, behaviors. So basically, each condition contributes to the development and maintenance of both disorders. There are unique clinical challenges when managing co-occurring substance use and PTSD. Both of these conditions are chronic, they are complex, and they are relapsing conditions. We know that comorbidity in general is going to complicate management. And these conditions are both associated with a wide range of impairments, unemployment and early retirement. We know that there are worse treatment outcomes for all conditions when there is comorbidity, increased service utilization, and increased all-cause mortality, including suicide. Fortunately, effective treatments are available, and in order to treat, you must screen. Dr. Dowling will speak about substance use screening. I do just want to highlight the importance of screening for co-occurring conditions, such as PTSD and depression. And also sleep disorders are very common. They're present in about 90% of individuals with PTSD. So assessment of sleep impairment is important. The Pittsburgh Sleep Quality Index is one scale to be used. And also notes that obstructive sleep apnea is something that our population often experiences. So sleep impairment should be noted and treated. For your reference, that's the primary care PTSD screen. I think everyone's familiar with the patient health questionnaire. The 9-item version does include questions about suicide. So it's important that everyone know about the 988 suicide and crisis lifeline. It really is an excellent resource available in English and Spanish 24 hours a day. And the counselors I found are really well trained and they follow up. So please make sure you have that as a resource for your patients. So at this point, I'm going to turn it over to Dr. Dowling, who's going to speak about alcohol use disorder and opioid use disorder.
Thank you very much. Talking about medications to treat alcohol and opioid use disorder. The reason why I'm focusing on these two areas today is these are the areas that have most evidence base and where someone in primary care might prescribe or will know that if they're referring to someone that there are medications that are available, medications for addiction treatment. Other areas, addiction specialists may prescribe, but the evidence base needs a bit more growth to be a higher evidence base. There is a good evidence base with tobacco, nicotine specifically. That's been covered in a different webinar. So when we talk about alcohol use disorders, I think it's also important to just talk about alcohol use in general and to keep in mind that not all use is a use disorder. And not all use is particularly risky, although studies would suggest that no amount is entirely safe. When we talk about risky use, we're talking about drinking a sufficient amount over time that someone has a much higher risk of various medical conditions or mental health conditions. And this has been studied dozens and dozens of times, literally around the globe. And for women, the limit where above this it becomes more risky is 3 drinks in a day or more than 7 in a week. And for men, it's more than 4 drinks in a day or more than 14 in a week. The numbers are a little bit lower for women because on average, women will have a smaller body mass and have a smaller liver and will metabolize alcohol at a slower level and therefore are more at risk for the physical and mental health consequences of drinking. On this slide, I wanted to emphasize that when we talk about alcohol, most people are aware of the liver, the pancreas, over time, some effects on the brain, but alcohol really can cause effects in any organ and organ system in the body. So we do need to be aware that there's a higher rate of respiratory infections, for example, that there's a higher rate of fractures and reduced bone density, for example, and muscle problems, muscle waning or myopathy, for example. And especially with cancers, that there are higher risks. We're already dealing with a group of people that have a higher risk of cancers to begin with. And some of them do overlap, but a higher rate of oral cancers, throat cancers, esophageal cancers, cancers of the liver, colon, and rectum, breast cancer in the larynx, and any of these cancers, the risk may be 50% higher or more than double the risk of developing cancers when someone is drinking that risky excessive amount, not necessarily with a use disorder. This slide shows from a study where they looked at an 18-year period in all causes of death and found that 3.5% of all deaths were alcohol related, accidents, also diseases. If you look at the list there, I'm not going to read it, but you will see that a higher rate of malignant neoplasms, chronic lower respiratory diseases, diseases of the heart, again, not just accidents and not just the liver and the pancreas. The other thing I wanted to point out here is that if someone is drinking too much, especially if it's a use disorder or has another substance use disorder, there's a higher rate of violence towards oneself, self-harming behaviors, including suicide attempts, but also violence towards others. And that's true regardless of underlying medical or mental health diagnoses besides risky substance or alcohol use or a use disorder. Now, when we look at the criteria for various use disorders, generally there are 11 criteria, and if someone has 2 or 3 that are positive, that's a mild use disorder, 4 or 5 is moderate, and 6 or more is severe. By the time someone is referred to my office, a psychiatric and addiction medicine practice, almost always there are 6 or more symptoms. Primary care doctors may catch it earlier, and it may be milder and earlier in the course, even if it is a use disorder. There are 4 categories that we look at that I think are easier to think about and remember than all of the 11 criteria. The criteria, by the way, may differ from one substance to another at times, but they're much more similar than different. So if you have a handle on alcohol, you'll be able to apply similar points to any other substance. If someone is losing control over their using, impaired control, they're using larger amounts for longer periods than they intend, or they want to cut back or reduce, and they're not able to do so. They're spending more time obtaining a substance, using a substance, or recovering from a substance. Someone may think they don't have a use disorder if they only drink on the weekends, for example, but if they end up having 10 sick days over the years on Mondays or after holidays, that's using excessive amounts and recovering, costing them work days, whether it's sick days or personal days, intense cravings or desires to use alcohol or that substance. We also look at social impairment, that someone is continuing to use despite developing difficulties at work, school, or in family relationship functioning, although that can include someone giving them trouble for their drinking or substance using. Often it's more than that. They're getting into arguments. They're not meeting obligations. They're not showing up at family functions. They're having trouble dotting their I's and crossing the T's on their presentations or projects at work or in their education or training. We also look at risk-taking or harmful use. So this certainly includes driving while intoxicated and could include falls from ladders, doing some mini projects at home under the influence, any ways that someone is putting themselves or others at risk. Now, one of the big things to keep in mind is if you're a primary care physician and you know someone is using alcohol or another substance and you're seeing some possible health effects, insomnia or a worsening of insomnia, a worsening of anxiety, elevated liver transaminases, and you're advising them that they should consider cutting back or stopping, and they're not, and these things are getting worse, that certainly are factors that you'll be able to see as far as risk-taking or harmful use. We also look at so-called neuroadaptive changes, tolerance, where someone is finding that they need larger quantities to achieve the same effect. And people's reasons for using may vary. It could be to get high. Some people really do use just to get high. Others, it could be self-medicating, lessening a negative mood or anxiety, or self-medicating physical pain. It also could be just to avoid the withdrawal symptoms. And withdrawal symptoms are different from one drug class to another. It's important to keep in mind benzodiazepines and alcohol have the higher risk for harm or even death if someone is in severe withdrawal. Other substances may be very painful, such as opioid withdrawal, but much less likely to be life-threatening. Something I wanted to point out when we think about addicting substances, including alcohol, is all addicting drugs and alcohol raise dopamine levels, raise endorphin levels or endogenous opioids in the body, and raise endocannabinoid levels. Endocannabinoids, you can see the connection to cannabis or marijuana, may also lead to high, but they're also involved in various coordinating interactions throughout the body. We need to learn more about those effects. Each substance may also have other areas that they affect, such as alcohol or benzodiazepines may raise GABA aminobutyric acid levels in the body or activity, and will decrease glutamate activity. GABA is the most common calming neurotransmitter system in the body, and glutamate the most common stimulating transmitter system in the body. When we talk about how to intervene, particularly in primary care, we talk about brief interventions, and I wrote brief and effective interventions because even if they're brief, following a method, they can be very effective. Brief counseling or education with a patient during an office visit or clinic visit, helping them to consider and maybe take steps to stop using or to reduce their using or to reduce risky behaviors that go along with using, can be conducted in 10 minutes or so, often less, and have been shown to reduce alcohol use, binge drinking, tobacco, and other substance use. We target the discussion to the level of risk and the complexity of issues that we're dealing with. Can also help us if we may decide to determine that this is beyond what we can do in our office and refer to a specialist, or in our practice, if we have some others who may be involved, whether it's helping with more detailed screening and diagnosis, or toxicology or other testing, or may be involved in monitoring and have time for follow-up visits. One of the models that we use with brief interventions are the 5 A's that I like to share because many primary care docs have learned about this with tobacco reduction and cessation. And I also want to remind people, when you talk with someone about tobacco, only 1 in 10 will attempt to quit when you have the discussion. Yet over the years, we've really reduced tobacco use, and it's a similar approach here, that you will have an impact on people, not everyone, but over time, you will have an impact on many people. We start by asking what they're using and how they may be using it, some of the reasons why, what they get out of it. Based on what they say, we try and have an even-handed conversation, not a lecture and not a scolding, and have a discussion about stopping if there's an interest, or cutting down if that's where the interest is. And we want to assess their willingness to really take steps in that direction and assist them if there's ways that we can that may help them to take some of those steps. That's where medications for addiction treatment, for example, may come in, or referrals to a counselor. We arrange for follow-up with them, or someone else on our team does, but we also want them to follow up with us so we can see how they're doing. Just as if you referred someone to a neurologist for a consultation or a cardiologist, you'd want to see them after that consultation. After you have this conversation, they're going to take steps. You also want to have a follow-up and see how things are working out. This is a large study, Madras, from 2009, if I recall, where they engaged in brief interventions, and often it was 1 visit. Sometimes it could have been 2 or 3, looking at alcohol and various substances. As you can see across the board, from baseline to 6 months, there were significant reductions in all of the substance use, even if many people did not choose to stop using. Now, we talked a bit about screening for alcohol and how much is too much. What I wanted to emphasize here is, what is a standard drink? No one really knows this anymore. It's actually 12 ounces of a standard alcohol, and many IPAs, for example, are 50% or 100% more alcohol, 5 ounces of wine, or 1.5 ounces of vodka, spirits, or brandy. So most of the time when people are having a drink in a bar or restaurant, for example, it's more than 1 drink the way we have measured it traditionally for years. The other thing I wanted to point out, that with the limits before alcohol use becomes more risky. Over 65, men and women, it's the same, 3 drinks or more, or 7 drinks in a week. These numbers are less than a lot of people would think. And again, keep in mind, we're talking about risks for many adverse health consequences, including development of a use disorder, but most do not have a use disorder. The difference between men or women narrows as we age because men, less muscle mass, and the metabolism may also slow down and get closer to or similar to women. One of the screenings you can use is the NIDA quick screen, and it's a single question for alcohol or for other substances. For alcohol, it's have you been drinking 5 or more drinks for men or 4 or more drinks for women in a day? And for other substances, the NIDA quick screen recommends that we would be asking yes or no. Now, that's probably going to have to change for things like marijuana, because not all marijuana use is terribly risky, but people are looking into that. We don't have good clarity there yet. And then you can go further, and the NIDA quick screen does give you 7 additional questions that can be asked to score people mild, moderate, or severe. And I thought it better just to go with the quick questions today. The single questions are easier to ask, and from there, start doing more of a detailed assessment in your office or refer if that's something you're not able to do. The audit is a well-known alcohol screening test, and the audit C, which is 3 questions, is just about as effective as the full audit. And if someone is scoring 4 or more, then there's a high likelihood that they have a use disorder, and you've already confirmed that it's likely they're drinking at risky amounts. There are a couple of withdrawal assessment scales that I point out because if you're trying to determine yes or no is someone in withdrawal, if you have these handy in your office, the CEWA for alcohol or the COWS for opioids, you can just go through this list and ask someone what they're experiencing. You can also score it based on severity, and it can help guide if you are prescribing medications to assist with withdrawal management, or what some still call detox. But the main point is just to have a good list of what the withdrawal symptoms may be. When we look at brief interventions, we often want to take a motivational interviewing approach, asking open-ended questions, expressing empathy, not judging, and having a curious perspective on what someone's doing and why, and their rationale, good and bad, for what they're doing. When you have areas of agreement, like someone's concerned that they're missing work, or they're worried because you've told them their liver function tests are elevated, or maybe their bone density dropped more than expected, and you think alcohol may be a factor, that's your buy-in. And certainly try to highlight areas where you agree. But it's also okay to highlight discrepancies where someone may feel that they're not running into trouble, but you've given examples that you've seen from your assessment or that they've shared with you, and you're curious as to what would make them say that now this is a problem, or why they don't yet see it as a problem. And based on what they say, you may help them build on some of their thoughts on how they might cut back or stop drinking, for example. Following up in primary care, I mentioned earlier, is very important. We want to follow up probably about every 2 to 4 weeks. And if someone's drinking at a risky level and they stopped or already cut back significantly, you might only need to see them 1 more time, sometimes a second time. It allows you to take a look at where they're at, see what's helping, what isn't. It gives you another opportunity to screen for a use disorder, and also to see if there may be co-occurring depression, anxiety, or traumatic stress. The overlap, whether you start with substance or start with PTSD and then look at the other, is extremely high. When might you consider referring to an addiction psychiatrist or an addiction specialist? Whenever there's a significant physical withdrawal symptoms and you feel there's a need for medical management of withdrawal. If there's multiple substances being used and it's beyond your experience to sort out what might matter for withdrawal, or how we may start tackling medications for addiction treatment, the number or severity of the psychiatric symptoms or disorders that may be co-occurring, depression, anxiety, traumatic stress. If you're trying brief interventions and you're finding there's a lack of success, either they're telling you over time that they were drinking, for example, more than they said, and they're not able to cut back, or whatever the goals are that they say they believe they can reach and they're not, after a couple of visits, it's probably a good idea to refer them to an addictions counselor or an addictions physician who may be able to help them go further with this. If they're not following through with office policies or procedures and you're feeling that the substance use is a factor there, that's a signal you may need a specialist. I've learned over time, and every addiction doc I've ever shared this observation with readily agrees. If the patient is asking for the referral, they need one. Odds are, if they're not telling you why, they're going to tell me within the first 10 minutes that they see me. This has happened anytime someone has referred someone and said, I wasn't so sure they need it, but they're insisting. And I chuckle and say, I'm sure they're right, and I'll learn at that visit. If someone has chronic pain, whether or not they're on opioid medications, but especially if they are, and it's difficult to manage them, even if they're using substances other than opioids, getting an addiction specialist involved is a good idea. When we talk about medications for addiction treatment, and as I said, our focus is on alcohol today. Agonists are methadone, and we have buprenorphine, which is a partial agonist. I did mention here that varenicline is a partial agonist for tobacco, but our focus is not on tobacco today. There are 4 medicines that may help someone reduce drinking. Acamprosate and naltrexone are 2 of them, and if someone takes them steadily and is participating in active treatment, about a third may be abstinent at 16 months, double the rate of placebo with each one. We also find that time until they have their first drink, the amount they drink, and being able to stop, they're more able to. Similar with naltrexone, and we see similar with topiramate. The topiramate is not FDA approved for alcohol use disorder, but it's strongly evidence-based. Disulfiram is an old drug, so-called antabuse, that essentially is a behavioral treatment. It interferes with the metabolism or breakdown of alcohol. You get an excess of acetaldehyde, which essentially is a toxin that makes someone feel terribly ill. So even though it's a medicine, it's more of a behavioral punishment, and it's generally reserved. It's hit and miss when it'll work. Someone really needs a partner who will work with them to assure they're taking it. When we look at pharmacotherapy for opioid use disorders, methadone is a full agonist, and to date is available only in methadone centers. We have buprenorphine that is a partial agonist that can be prescribed in a physician's office. And we also have one antagonist, naltrexone. And I mentioned specifically the injectable with the naltrexone because the oral naltrexone, which may be effective for alcohol, is not effective at all for opioid. It's got to be the monthly injection. When we look at buprenorphine versus full agonists, the full agonists like heroin, methadone, morphine, look at the red line, the receptors become saturated and you can get a full effect. And increasing doses can really keep increasing the effect until someone can be very impaired and sometimes stop breathing even. With buprenorphine being a partial agonist, so it blocks the receptor as an antagonist at the same time it stimulates. There's a ceiling to the adverse effects, and you really can't overdose on buprenorphine. Another thing I wanted you to look at is when we look at opioid agonist therapy, at the left side of this slide, you see healthy person in early usage, they're getting a higher euphoria, and then they go back down to their regular state. But gradually over time, everything drops off, and after a while, they're using just to stay normal and to stay out of withdrawal. And if they go on buprenorphine, it's going to keep them in that middle ground. So this is much more than just substituting one opioid for another. It's keeping in that feeling reasonably well state and allowing them to then work on things individually in 12-step mutual help groups with a therapist or a program. Naltrexone injectable as the antagonist I had mentioned before. It can be very effective. However, what we find is that over time, people tend to drop out of treatment higher there than with buprenorphine or methadone. There's also more long-term data on the other two, although it's growing with the naltrexone. You have to be opioid-free for a week and a half to 2 weeks before you can start it, where you can precipitate withdrawal, and that can be tricky as well for someone to be not using anything and not have the protection of one of these 3 medications. And I'm going to finish up mentioning briefly naloxone. Narcan would be a common brand, which is an opioid blocker that can be given intranasally to reverse an overdose. It takes 2 to 5 minutes to work and can last an hour and sometimes a little bit longer. Some people think of this more as harm reduction, which it is, but it really is part of the continuum of treating opioid use disorder in particular. And with that, I will finish and pass the baton back to Dr. Lowe to finish our presentation.
Thank you. Okay, so Dr. Dowling spoke about some of the brief interventions that can be done in an office visit. And I hope that you realized how much you actually can do in some of these brief visits. I'm going to talk very little bit about psychotherapy and psychosocial strategies. So, mutual help programs, cognitive behavioral therapy, couples and family therapy, they're all effective strategies for treatment of substance use disorders. They have common elements in that they're goal-oriented, they're all very patient-centered, they offer skills for coping and focus on reinforcing a social support system. I'm not going to talk about couples and family therapy at this time. So mutual support programs, these are the 12-step programs that most of you are familiar with, Alcoholics Anonymous, Narcotics Anonymous, Al-Anon, and they are the most widely used recovery programs. They are very valuable in achieving and maintaining sobriety. However, they are optimal in combination with other treatment modalities. And one of the real advantages to this is that they are widely available and they are free of charge. So that makes them very useful for a large number of individuals. Now, in any treatment planning with patients, it's really important to use a collaborative approach and kind of, as is often said, meet patients where they are. And in particular for substance use and individuals with a history of trauma, there needs to be a flexibility because what you really want to do is engage patients. So the 12-step programs focus on abstinence and acceptance of the powerlessness over the substance of abuse. There is an element of spirituality, and it's a program that's very pragmatic. There are steps that you follow, and you really need to be active in it. Again, very effective for many individuals, but it is not for everyone. I did want to make sure that you were aware that there are other approaches focused on harm reduction. And essentially, these approaches support any reduction without the requirement to abstain from the substance. And it really aims to reduce the negative health and social effects of substance use. Individuals who engage, providers who engage in harm reduction approaches really need to have a non-judgmental and non-stigmatizing perspective because there's so much shame already in substance use that there needs to be a sensitivity to that. Cognitive behavioral therapy is an evidence-based type of therapy that's been very effective for substance use. Some of the advantages of CBT are that it is time limited. It can be administered either in group or individual settings, and it's very goal oriented. Some of the ways that it helps individuals is by helping them develop strategies for communication. So for example, how do you refuse a drink where you're at a social event? How do you set boundaries when someone is trying to say, oh, just have one? How do you ask for help, especially in a work environment? And it also helps with developing skills such as mindfulness, exercise, and hydration. Sometimes people are drinking because they're thirsty. And if you hydrate, it really helps cut back. It also helps individuals prepare for a lapse, which in all likelihood is going to happen. So developing a relapse prevention plan, identifying what that individual's triggers are, how to avoid the people, places, and things, high-risk situations where they're more likely to use substances. And for our cohort, one of those happens to be September. The anniversary reactions are common times of increased stress or distress, and places people with substance use disorders at higher risk. So it's important to be able to talk to them ahead of time about this. And another aspect is kind of reframing, so that in all likelihood, people are going to relapse. It's not a catastrophe. You can learn from lapses. You can limit the consequences if you catch them early. So again, these are all elements of CBT that are really helpful. Now, I'm going to touch very briefly on on the treatment of dual diagnosis. We know that PTSD and substance use disorders are mutually reinforcing. They're bidirectional, and that's consistent with the mutual maintenance model. And we also know that reducing use of substances without treating the PTSD symptoms is extremely difficult. That goes back to the self-medication model. So currently, a best practice is the integrated treatment approach, where evidence-informed interventions are delivered simultaneously. So essentially, what this means is that you can offer medication-assisted treatment and psychosocial treatments for substance use disorder alongside all psychotherapies or pharmacotherapy for PTSD. There is no need to use a sequential treatment approach. Some of the disadvantages of this is that you do need people who have expertise in these therapeutic approaches. And that's frankly a challenge to find. One of the approaches is called COPE. That's been very effective at reducing both PTSD and substance use symptoms. And a key element here is educating patients about the relationship between their substance use and PTSD, or depression for that matter. You would be surprised how helpful this can be when people make that connection. And it's really highly motivating for them to put that together, and they feel more hopeful about the engaging in treatment. But that is just one approach. There are many different approaches. The main message is don't when you have both of these disorders that are active, treat them both to the extent possible. Okay, so in summary, it's now more than 2 decades after 9/11. We know that there are many individuals who continue to have active symptoms of many related conditions. And the co-occurring substance use disorders and PTSD is common despite the certification numbers. We know that they are both associated with high relapse rates. These individuals have chronic illnesses that are going to require ongoing treatment. And we know that not treating these disorders is going to lead to worse outcomes for all health conditions. When assessing individuals with substance use disorders, especially in our cohort, make sure that you're also screening for trauma symptoms, and I'll throw in depression too. The clinical practice guidelines recommend the medication-assisted treatment and or psychosocial therapy for substance use, and for combined dual diagnosis, integrated treatment is what is recommended. And I hope that one of the things that we have both emphasized is the importance and the role that you all serve in helping individuals with these very serious disorders. So I am going to stop sharing here and leave some time for Q&A.
Thank you so much, Drs. Dowling and Dr. Lowe. We do have a question on access quickly or routinely to the resources patients have. So the question is, do you have any thoughts that you can share of how to access quickly or routinely what resources patients have? One of the recent presentations on the mental health form that the program holds suggested digging a little deeper when patients respond with fine to the questionnaires regarding how they're doing. And if survivors don't meet the physical or mental health criteria for the program, they may benefit from reminding them to follow up with their primary care doctors or counselors compared to World Trade Center responders who can be reassessed annually. Do you have any advice or thoughts that you can share on that for resources for patients?
Okay, just to clarify, these are resources for patients who do not have World Trade Center certified conditions, but have PTSD or substance use due to some other causes? Is that the question?
Just the thoughts on how to quickly assess or routinely assess the resources that patients have. I think maybe a general approach on that you can expand upon from the presentation.
The screening that is done during monitoring is very efficient. And also during monitoring, there is a tool called the Beast, which also very quickly assesses for psychosocial needs for that individual. And it's an opportunity to provide them with the resources that all clinical centers should have. So those are, I think monitoring is a very effective way and efficient way of doing that.
And then I'm letting the person know if they have any follow-up questions, they can reach out to us. For patients with opioid use disorder who require opiates for pain management, how should primary care physicians approach that situation?
This is a great question to ask, and I would look at it in, I guess, two general situations. One, if it's acute need, and sometimes that could be planful, such as a surgery. It could be someone had a fall, an accident, a fracture. But the way many addiction docs will handle this is, although buprenorphine is an antagonist, if you stop it, within a day, an opioid pain med will give pretty good benefit, or within 2 days, very good benefit. So for example, if I have a patient who has a planned surgery next Friday, I'll tell them stop taking the buprenorphine by Thursday afternoon. Friday, they have the surgery. Post-op, if they need pain medications for a couple of days, they can start taking the meds and they'll do well with that. And then as long as it's just a few days, 2 or 3 days, they can stop the pain meds and go right back to the buprenorphine. By a week, they probably need to get in touch with me, and we need to planfully have them go into withdrawal and then restart the buprenorphine. But the advantage is we know each other, we know the dose that we're targeting, we can go right to that dose right away. If someone has an urgent situation, a car accident, a medical problem that pops up, and they require opioid pain management, then we stop the buprenorphine, and within a day there's going to be more relief. But initially that could be challenging. But some of the opioid agonists available by injection or IV, hydromorphone and morphine in monitored situation in a hospital, can break through the buprenorphine to some degree. And there aren't great controlled studies in these very unique situations, but there's a lot of observation with addiction specialists doing this over years. I know in my own practice, we've done this about 50 times, including people in their 80s with knee replacements and hip replacements, or having a fall and surgeries. And it's worked out very well each time.
Thank you, Doctor. I'm going to hand it back to Dr. Calvert to finish up the webinar.
Thank you, Ann. And actually, I realized I forgot to introduce myself at the beginning. So I'm Dr. Jeff Calvert. I'm with NIASH, with the World Trade Center Health Program, and I'm the Associate Director for Clinical Quality. And I also want to recognize my 2 colleagues who assisted with today's webinar. You just heard Ann Riddle, who was asking the questions. And also behind the scenes is Kiana Harper. So I very much appreciate the 2 of them for all of their assistance. And also I want to thank our great speakers for an interesting and compelling presentation and webinar. So thank you so much, Drs. Lowe and Dowling. And so finally, for the get your continuing education credits, it's a little complicated. So I would recommend that you take a screenshot of this screen. So what you need to do is log into the CDC train system. And if you're not registered, you'll need to register within that system. It's easy. And if you could also just Google CDC train to find this website. Once you're on the website, you've logged in, to find this course, the simplest way would be to type in the WC 4740. You could also include today's date at 12/12/24, but if you just use WC 4740, you'll find the course. Then they're going to ask you for a registration code, which is World Trade Center Health Program, that WTCHP. You'll only need that for the live webinar. And if you're watching the recording, you'll use a different code to find this lecture within the CDC train system. So that code would be WD 4740. So then once you're logged in, you've registered for the course, you will then select the type of CE credits you want. You'll complete the course, you'll hit the Mark Completed button, take the post-test. You'll have 2 chances to take the post-test. There's going to be 4 questions. You have to get at least 3 of them right, and then they'll ask you to complete an evaluation. So for this live lecture, you can get the credits for up to 30 days. And then if you miss that 30-day period, you can get the credits for the recording, which will be available for actually 4 years from today. So you have lots of time to get your CE credits. So with that, it's the end of the hour. I want to thank you for participating, for joining our webinar, and wishing you all a wonderful rest of your day. Thank you very much.